Caring for patients in a hospital setting is complex. Every patient is different, with different strengths, weaknesses, and abilities. As caregivers, it is our job to identify these differences and work with the patient in a way that keeps them and us safe, and at the same time promotes them to maintain or improve their level of functionality. In previous videos, transfer techniques from moving a patient from a bed to chair, chair to bed, sit to stand, and squat pivot transfers have been explained and demonstrated, and those are great for a patient that shows some general weakness. But how can we personalize these same techniques if the patient has one-sided weakness from a stroke, or weakness associated with MS or Parkinson's, and how can we safely transfer a patient with an amputated leg? In this video, we will look more closely at using these transfer techniques for specific diagnoses and their related weaknesses. We'll be transferring a patient between a bed and a wheelchair, and adapting to these various degrees of weakness. No matter what technique you'll be using, always begin by setting up the environment and the patient. Sit the patient at the side of the bed. Clear the bed of unnecessary sheets, cords, etc., and bring the wheelchair close to the bed. Whenever possible, position the wheelchair so that the patient will be transferring toward their strong side, if they have one. In this example, the patient is moving from the bed to the wheelchair with the wheelchair on their left because we've identified the patient's left side as their strong side. Contrary to this example, where she's moving to her right from the chair to the bed. In this example, we've identified her right side as her strong side. The wheelchair should be as close to the bed as you can get it. Positioning at a 45-degree angle is helpful, but if not possible, putting it flush to the side of the bed will work. Once the wheelchair is in position, lock the wheels. Apply the gait belt to the patient, then have the patient scoot to the edge of the bed or chair. Prompt the patient to do as much work for themselves as possible. Have them push into the bed to help scoot forward, but make sure that you are always holding the gait belt for stability, and to assist with the scoot whenever necessary. When at the edge of the bed or chair, ensure their feet are well positioned. The knees should be bent at 90 degrees or the toes should be below the knees. If the feet are ahead of the knees, supporting their own weight will be very difficult, and they will likely fall back. The feet should also be shoulder-width apart. With a patient that is able to stand, get them into this position and have them lean forward to put their nose over their toes and push up from the bed with their hands. You can assist from the gait belt. Having the patient in this position makes this significantly easier for both the patient and the caregiver. For patients that can't stand, transferring using a series of lateral scoots can be safe and effective, and will begin with the patient in the same position. This patient's right side is weak. If she is going to fall, it will be towards the weak side or falling forward, so the caregiver should position themselves in front and on the weak side of the patient to give support and protect them from a fall. The caregiver can also support the patient and prevent a lean or fall to the weak side by holding the gait belt behind the patient on the weak side. This will force the caregiver's arm to cross the patient's weak side and act as a brace or support against a fall or lean. If the patient has little to no strength in the weak leg, the caregiver can stand and sandwich the weak leg from the foot up to the knee between the caregiver's legs. This will hold it in place and prevent any sliding during transfer and prevent the knee from buckling. If there is some strength and stability in that leg, the caregiver may not need to sandwich the leg. They may not need to support that leg specifically and could just stand with a nice wide base of support to make their job a little bit easier. But if the patient can't keep their leg in position and it slides out, the caregiver could just block the patient's foot with their foot and prevent the patient's leg from sliding out during transfer. If the patient's arm is also weak, the caregiver may need to support that limb by holding it and the gait belt in the same hand as you assist with the transfer. The goal of a lateral scoot transfer isn't to make the distance in one scoot, but rather in a series of small movements. The first scoot should move towards the chair and turn the patient's hips slightly so that they are angled toward the chair. Have the patient help as much as possible. Place the patient's hand on the bed where you want the patient to scoot. It gives a visual and tactile cue along with the verbal, which is very helpful to patients, especially stroke patients, where cognitive level may have been impacted by the stroke. This variety of cues to the patient can help ensure they understand fully what is expected. To perform a scoot, have the patient lean forward over your shoulder as you squat low from your legs. Your strength should be able to come from your legs and not your back. The patient should lean over the shoulder opposite from the direction of the scoot. This helps the patient by lifting their bottom off the bed in the direction of the scoot and allows the patient to lead with their butt instead of their head, which helps with balance. However, if you identify that the patient has severe weakness on their weak side with very little trunk control, so much so that by leaning in this direction, you would be forced to fully support the patient's weight, that's unsafe for you. And you can have the patient lean toward the direction of the scoot instead. You lose the benefit of the directed butt lift, but the scoot can still be effective, and it will be safer for you and your patient. While you're holding the gait belt, blocking or bracing the weak leg, and directing the patient to lean over your shoulder, direct them to scoot their butt to their hand. They should push up with their strong side as you aid and support from the gait belt. Just a short scoot toward the chair, and position the patient angled toward the chair if possible, instead of at a 90-degree angle to the chair. It'll make the next scoot easier. Before performing another scoot, check to make sure the feet are still positioned correctly, and reposition them if necessary. Remove the arm of the wheelchair if it is removable. This gives an unobstructed path to the final destination. Then place the strong hand on the seat of the chair, the stopping point for our next scoot. Follow the same steps as with the previous scoot and guide the patient onto the chair. Then have them grab the armrest with their strong hand, check foot placement, and direct the patient for a final scoot to sit fully into the chair. When the patient is in position, reattach the armrest. The lateral scoot transfer is a useful, safe, and effective method of transferring a patient between a bed and a chair. It's especially useful with patients with one-sided weakness, but if your patient just shows general weakness, the lateral scoot transfer is still appropriate. But as the caregiver, you don't have to put as much effort into controlling the weak limbs. Similar to a lateral scoot transfer, you may find need to utilize a slide board to transfer between bed and chair. Generally, a slide board is needed when the patient is not able to lift up enough to perform a lateral scoot. The slide board allows them to perform the movement without needing to lift as much. This can be useful in strokes early on, and MS, and they are used regularly with above and below knee amputations. In all of these examples, the one thing you need to ensure before using a slide board is that the patient has good trunk stability while sitting. If they are not able to maintain a seated position at all, this is not a safe transfer technique for this patient. Set up the environment and position the patient the same as you do for a lateral scoot. You'll need a slide board like this one shown here. They are sometimes made of wood, and they sometimes have handholds cut out of the sides, but they are always long boards that will bridge the distance from one surface to another for the patient to slide on as they transfer to a new destination. As the caregiver, position yourself on the weak or amputated side. If the patient is going to fall, it will be toward this side, so position yourself to protect the patient and prevent the fall. Remove the armrest of the wheelchair if possible. Then you'll need to get the slide board under the patient. Support the patient as they lean in the opposite direction of the transfer. As they lift their bottom off the bed, slide the board under them and help them sit back up. They'll be leaning to the weak or amputated side, and if the patient can't perform this because of poor trunk control, and you would need to support them fully, the slide board would not be the appropriate transfer technique for use here. When placing the slide board, you want it more under the patient's thigh than under their buttocks. If it's too far back, it may cause the patient to slide forward on the board as they perform the lateral slides, and that could lead to a potential fall, or at least force you to stabilize and support the patient more than necessary. If the board is under the thigh, the patient's weight is more evenly distributed front to back as they perform the transfer. If you're transferring to a wheelchair, as we are here, turn the board so it clears the wheel and is resting on the seat. As the patient slides, the technique is the same as for a lateral scoot. Feet should be below the knees. You can block the foot or knee as necessary. Have the patient lean over your shoulder opposite the direction of the transfer as you hold the gait belt. Have the patient push on the board with her strong arm to help slide toward the chair. Use the hand not only as a support for the slide, but also as the destination for the slide. Try to get the patient's butt to where the hand is. Take as many scoots or slides as you need, and once the patient is close enough to the handrail that she can reach it, have her hold the handrail with her strong hand. Perform another slide to get fully onto the seat. Then have the patient lean slightly so you can remove the slide board and lock the armrest back into position. The next transfer we will demonstrate is the sit to stand using a walker, but with a patient that has weakness related to Parkinson's. Patients with this diagnosis tend to hold most of their weight on their heels. They are at a higher risk for falling backwards because of how they distribute their weight. They can transfer safely with a walker, but it is important to understand the nuances of assisting these patients to keep them and you safe. Get the patient positioned the same as with the other techniques. Edge of the bed or seat, with toes below their knees or knees bent at 90 degrees. Have the walker in front of the patient and ready to be used, but never have the patient grab onto the walker before they stand. Position yourself to the side and posteriorly. Unlike the lateral scoots with one-sided weakness where the patient would probably fall forward or to the weak side, Parkinson's patients will probably fall backward because of how they hold their balance. So you should position yourself posteriorly to protect against that. Ask the patient if they have a weak side, which is possible with Parkinson's, and if so, try to position the patient so that they are transferring toward their strong side, and you will be positioned on the weak side and posteriorly to protect against a fall. Instruct the patient to bend over to get their nose over their toes. They need to lean over a lot. probably more than the patient realizes, so encourage and cue them to bend over fully.
Nose forward, 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 lean forward.
Then push up from the armrest to stand. When standing and still leaning forward, grab the walker with one hand and then the other. Then stand up. The Parkinson's patient will start to put their weight on their heels, so you will likely have to continue to prompt them to lean forward.
And now, lean forward, lean forward, lean forward. Try and find your balance.
And find their balance. Stay close to the patient, guiding and supporting from the gait belt as you instruct them to take small steps rotating toward the bed. With their back toward the bed, have them take small steps backwards to get close to the bed. The Parkinson's patient will now have a tendency to lean back over the bed, which can quickly lead to them losing their balance and falling onto the bed as their feet slide out in front of them, which we want to avoid. Prompt the patient to continue to lean their nose forward over their toes to keep the weight forward as they sit. Prompt the patient to sit by bending their knees, leaning forward and keeping their nose over their toes for the whole process. This keeps their weight balanced as they sit and helps avoid the fall. Continued verbal cues are always beneficial, especially with these patients. You need them to keep their weight more balanced than they naturally want it to be. If they aren't actively trying to lean forward, the Parkinson's patient will always resort to holding their weight over their heels. So keep talking and prompting through the entire transfer.
As much as you can. Yep, bring your nose forward, bring your nose forward. More. Bend forward, so bring your nose over this. Come on, forward, 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 forward. Now bend forward and start to kick your butt back. Sit on the edge of the bed. So reach back, sit on the edge.
Promoting the maximum mobility in our patients is pivotal to recovery. We always strive to have the patient do as much as they can in a way that is safe for both the patient and the caregiver. These are just a few examples of how we can personalize mobility and transfer techniques to match the abilities of some common diagnoses and weaknesses.